So we've now got an update on congenital cardiac surgery by Andrew Parry, the executive co-chair on behalf of his team. Andrew.
Thanks very much, Lorraine and Society. I'm going to give you a brief update on where we are with the congenital subcommittee. Within congenital cardiac surgery, it's very difficult to do anything as a group of surgeons because we're so intricately related with the cardiologists, and we have joint care of patients as opposed to complete, dare I say, control over exactly everything. And we're also very intricately connected with the CRG. So many of the things that I'm going to be talking about this afternoon, very briefly, are interconnected with both of these two groups. And I'm going to actually give you an overview on what the CRG is doing as well as the society, because we're, as I said, so intricately related. These are the 5 main headlines. It's all right. There are very few slides about each of them, so it's not going to be a long thing. And a number of these things, again, are updates on where we were last year. The things that are facing us really haven't changed. They've just got more intense, and our approach to them is somewhat developing. So workforce concern, is there a control? Oh, is this it? Yeah. Well, there we go. Workforce concerns. It's just, this is a slide which I showed last year. It's a very concerning slide that the number of surgeons who are leaving the country over the last 10 years was 34. Some retired, yes. Some moved within the UK, yes. But most of them went abroad. So we have about close to 40% turnover of congenital cardiac surgeons going abroad. So the key question is why we're losing them. And the other really concerning thing is, of those people who came, 46 new surgeons joined us. Only 18 of those came through the British training system. Now, there are a number of reasons for this, for both aspects of this. The thing that's really concerning is that of the number of consultants who are leaving the country, they're often the experienced top end being age consultants who take away a huge amount of experience, and our national experience drops enormously every time one of these surgeons leaves. The concerning thing about the number of surgeons who have trained in this country is twofold. One is the attitude of the units who are employing a new surgeon. And dare I say, many of us are looking for a surgeon who can come in and deliver the service, or we have done over the last 10 years, someone who's able to deliver the service, particularly when you've lost one of your senior consultants with a lot of experience. And you have some young consultants there, you have some people who are finding their feet themselves, as well as having to mentor somebody. So we've taken mentoring on in a big way, and hopefully the issue of employing a fully fledged surgeon is of less importance nowadays. And the other thing is the interest that we have within our trainees and whether they're interested in coming to be congenital cardiac surgeons or not. I would say that we are in a time of transition. I know that there is a small, but we are a small specialty, very committed cohort of senior medical students and junior surgeons who are coming through, who are completely committed to congenital, even at their very young stage. But that's going to take a few years for them to work through. So we have to get to that point in the meantime. So what are we doing about it? Here we say, many of the reasons why these surgeons are leaving and going abroad are completely out with our control. Lifestyle, money, opportunities, particularly research opportunities, which I don't think the congenital subcommittee is in a position to address at the moment, but I'm sure Narain's got deep pockets, so we'll be talking to him shortly. The mentoring I've mentioned. What we are doing is trying to recruit and encourage these young surgeons to get involved as early as possible. So one thing that has happened and is ongoing at the moment is that we are giving the ST1 or 2s a taster session in congenital, because one of the criticisms that we've faced is that trainees are not exposed to congenital cardiac surgery until well into their career pathway. And many of them turn around and they say, oh yeah, we love congenital, it's very interesting, but I have done so many years of this, I've got my mindset on being an aortic surgeon or a mitral surgeon or lung reduction surgeon, is that what they're called? Something like that. So I'm not going to change my pathway now because I've got my contacts all set up, but it would have been a nice thing to know about. So we now have these ST1/2 taster exposures to congenital surgery. It is at the moment happening on a sort of ad hoc basis. Shafi Musa is leading on trying to get this on a more formalized thing. And he has spoken to Mahmoud, I believe, in getting a sort of list of requirements for what would be necessary to offer one of these for each of the groups. And from this, he is then going to advertise it around a fraternity, seeking expressions of interest for people in various units wishing to offer this to the younger people. The other thing that we're trying to strengthen, it's always been there, but we're trying to strengthen it, is in the ST4/5 era, is to have a highly encouraged exposure to congenital surgery. Of course, you can't oblige people to do exposure to congenital cardiac surgery, particularly because not all deaneries have got a congenital center within them. But if we can strongly encourage the trainees to come through and to seek a congenital exposure at some stage, then hopefully be able to catch some of these older ones who haven't quite committed to their final pathway at that time. However, can I go back? Yeah, however, and this is a big however, and I haven't put a slide up about this because it's a bit contentious, but the number of congenital heart operations that are performed in this country over the last 10 years has fallen by 15%. And all the modeling that was done for brevity, I'll call it the safe and sustainable process, which is, I know is highly contentious. All the modeling that was done on that was a continual increase in cases, live births with congenital heart disease coming through the country. The long and the short of it is that these models have proven to be incorrect. And the number of operations, if you look at the year-on-year data, it's fallen about 15% over the last 10 years. So the truth of the matter is, do we really need as many congenital cardiac surgeons as we have at the moment? So I said this was contentious. So there is work that is going on, starting at very recently with the CRG, looking at the whole of the congenital workforce issues. And as many of you will know, there was this thing called Safe and Sustainable, and then there was Son of Safe and Sustainable, which basically developed a number of criteria by which a congenital cardiac surgery service had to define and justify its existence. As far as surgeons are concerned, we're pretty narrow-minded. The two ones which particularly affected us were 4 surgeons per unit and 125 cases per surgeon. And with the distribution of centres and population within this country, from the very beginning, there was concern from a knot of the fraternity that these were not compatible. And so there is now discussion going on as to whether we should be reviewing these standards again. I haven't put a slide up. It is contentious because it strikes at the very heart of the way that the congenital program has been set up nationally, but it is something that we need to do with this falling workforce, with this falling birth rate. Then we are not going to have as many cases for congenital surgeons to operate on. It is true that more and more patients are surviving to adulthood, and therefore the Gooch population is increasing enormously. That is the growth area of congenital cardiac surgery. And there may be a requirement for reorientation of training so that there's some of our trainees who focus particularly on the Gooch work that is work that we are looking at. We'll see where we get to with the recalibration of the standards and what appetite there is for that. In this, the other very important thing is that we work in what is called a national health service. And I'm sure in your own practices, just as much as in the congenital practice, there is quite a differentiation around the country of what is being able to be offered to patients and, in our case, to the families. And the most recent waiting list figures, they were published since I had these slides, so I'm sorry I haven't included it here, but the most recent waiting list slides show that there are some centres where the waiting list is extremely short and others where the waiting list is very long. It's probably just as well I haven't got the slides because it's not appropriate to label any particular centres. Another thing that is happening now within the CRG, and it is something which needs to be done on a cardiology as well as a surgical level, rather than just a purely surgical level. But for the first time, there is a negotiation between two centres within the country as to sharing semi-formally some of the workload so that the waiting lists are evened out around the country. I personally see that as a great step forward because there is an enormous stigma, as we all know, if we have to ask another centre to take some cases because we are unable to deliver it. However, as I said, we do work within the National Health Service, and therefore I think it's appropriate that we deliver service between ourselves in the best possible way we can, so all our patients have given the same opportunities. NICOR issues, I haven't got much to say here. The frustrations with the NICOR process are very much, as we heard from the adult side from Dimitris earlier. We in the congenital side are very much following on from your lead and enjoying the success that you are having. And Sherban Stoiker and Karen Van Dorm are leading the congenital side on it. And we're sort of mirroring what you are and following in your footsteps. So one, we thank you for that. And two, we are making progress with the agreements with Dendrite and with the data control of the University of Bristol to take this forward. Because as you said, and is actually the frustration of all the cardiovascular elements of that particular work stream within NHS England, everyone's frustrated that we send loads and loads of data and we just don't have any access to it. And all the wonderful research opportunities that we have in longitudinal studies just aren't available to us, even if we pay a lot of money for it. Seem to bring up contentious things this afternoon. Again, something I mentioned last year in its infancy. There is a proposal, there is an observation within the subcommittee that whereas the written exam has congenital elements, a significant congenital element to it, the actual final third part fellowship exam, the vivas, etc., and the clinicals have no congenital input whatsoever, apart from bicuspid aortic valves. So we are proposing, and we have had discussions, the SAC with the JCIE, as to whether one of the final exam streams, as well as adult acquired thoracic, could be a congenital examination. Initially, there were concerns that this could not be quality assured. But there have been discussions and there have been reconsiderations about this. And I believe that we are now starting to move forward on it. And there are opportunities that we will be able to offer in a few years' time, because of course we need question banks, et cetera, and trained examiners, that in a few years' time, then we will have the opportunity of offering a congenital final examination. So progress on that this year. And the other, or another issue that we have been sort of leading on is homografts. The reason we've been taking it on is that I think it's fair to say we use more homografts than the rest of you put together. So it's not a subject which is solely for us, but we're trying to lead it for all of us, because I'm sure, or would hope, that most cardiac surgeons would at some time in their career think it would be useful to have a homograft here because it's going to get me out of a sticky situation. Problem we have here is very similar to all the other transplant issues, that there is an inadequate supply of donors. And as you can see, for about 10 years, there has been very little increase in the donor pool that we've had. These are the official figures, or these are certainly the last official figures that I can get hold of so far. And it shows you the unfulfilled requests that are received by NHSBT in Liverpool. I think they must just be logging my calls for unfulfilled requests, because there are many, many of them. And I just put this up to emphasize the fact that there is an issue with homografts. Mainly, they affect us, mainly the little pulmonaries or the pulmonaries, but aortic valve homografts for adults, I'm sure many of you would appreciate one of those for a infective endocarditis case every now and then. And certainly we can use some of those in Ross's, and I know some of the adult Gooch surgeons would appreciate those. So we don't have enough of them. So what are we going to do about it? Well, we've been in discussions with NHSBT, and we've had a meeting with the organ retrieval teams. There are a number of organs that when they go to harvest, that they're not suitable for transplantation, and therefore they leave them. So we've emphasized the fact, get hold of those, because we can still take valves from them. There are also situations where, say, the lungs are no good, but the heart is, so take the heart out and they leave the pulmonary arteries. We suggested to them, take the pulmonary arteries as well. We can make patches out of those. We can, use every bit that we can get hold of. So we have had discussions with the organ retrieval teams. Again, there are a number of patients who kidneys, liver, gut can harvest all of those, but the heart and lungs aren't acceptable. Therefore, they take the heart out and send it off to Liverpool for valve harvesting, but they don't remove it in the right way. They cut the aorta or the pulmonary artery too small, or things like that. So we've had an educational time with the organ retrieval teams, trying to explain to them the importance of getting maximum lengths of all the great arteries you possibly can do, treat the hearts with great respect, even if we're not going to use them as a viable organ, to maximize that. The last discussion that I've had was with Steve Suey in the transplant subgroup, because a number of these hearts which are taken out from the recipients, the myocardium may be non-functioning, but certainly the aortic valve may be perfectly reasonable. So why don't we take the valve from the recipient heart? So he is going to take that back to the group, and we're going to hear what they say. Hopefully we'll be able to get some more aortic valves that route as well. I understand it's not really practical to get pulmonary valves out of these recipient hearts because of the length of pulmonary artery that is required when you do a heart donation. But if we can get some more aortic valves, then every little helps. And the last thing I was going to mention with the PECTIS guidelines, but I know that Man has talked eloquently to that earlier on. I've just put the pediatric side of it forward, in as much as the centre in Barts, they had done a very, very small number of children, but it is, I understand, predominantly an adult service. But this second call for interest, I understand that they're looking at a pediatric centre as much as they are an adult centre. So hopefully we will have an input to the care of children with PECTIS. Many who I understand, a very long time since I've done a PECTIS, so I'm certainly not an expert on it, but many of these we wouldn't treat until they get to teenage years and through puberty, because of the growth of the skeleton at that time. But as you heard earlier, it's far more than just a surgical or an orthopedic sort of operation. It's the whole care of that child. And we need a centre which is able to look after these children through the childhood years when their peers are the cruelest. And we need to be able to support them, look after them, and help them through that time as well with these other things, which may hopefully mean that we never actually have to get to an operation at that time. So there is some movement on the pectus thing, of course, led by Aman and his excellent team, looking at progressing it for children as well. And that summarizes the congenital subcommittee.